colorectal cancer, which is what we're going to be talking about today, is a very important cancer, and Australia and New Zealand has the highest global incidence of this disease, which, in some ways, it's like we're the champions for numerous reasons, some of which I will elaborate on in a minute. We can say by some sort of statistical sleight of hand, if you like, that it is the commonest cancer that can affect both men and women. Because some of the other common cancers can only affect men, and some of the other commoner ones also affect women, but colon cancer or colorectal cancer affects both men and women. There is a lifetime risk, if you extrapolate lifetimes to about 85 years, of about 1 in 10 in men and 1 in 15 in women. And it's the second biggest cancer killer in Australia in 2016, and currently, with about 17,000 deaths, diagnoses a year, with 4,000 deaths every year. The biggest killer, of course, is lung, but colon cancer is second. Okay, I hope you will excuse us. We are sort of all trying to investigate new technological advancements, and there is a little bit of a learning curve here, including our late start, which may have something to do with daylight saving in the East, but I'm not sure whether it is truly that or not at all. Okay, right. So if you look at the incidence and mortality of colon cancer, the top rows or the top parts of the graph are looking at incidence, the blue for males. You can see that over the last 35 years, the incidence in males may be slightly dropping now, having reached a peak earlier, whereas the orange line below, the solid orange line below, in females hasn't shown much of a change in that time. Interestingly, there might be reasons in Australia, for instance, with rising risk factors such as obesity and so on, where we cannot assume that these changes in incidence will continue to trend downwards. It is not that clear. But hopefully with other programs like screening and colonoscopy and earlier detection, removal of polyps, et cetera, there may be a chance that incidence will go down, as it has in the United States. If you look at the lower two dotted lines, there has been a dramatic reduction in colon cancer mortality over the last 35 years. Certainly in the days in the 80s when I was a medical student coming into becoming an intern, we were always told that 50% of colon cancers at diagnosis will die of the disease, whereas nowadays it's only about 25%. So there has been a significant improvement in mortality, in part because of earlier diagnoses, but in part also because of some advancements in technology in terms of managing it. Okay, so I'm not sure where we're up to in terms of the slides, but I've just put on a slide now that shows you the age-related incidence of this disease. And the thing that I really want to highlight is that there is not much action in colorectal cancer if you look at people, say, below 40. But from 40 onwards, the curve starts to go upwards, and especially at the 50 sort of level, it becomes essentially exponential. And so this is a very, very important point, that by and large, it is a disease of people who are middle-aged and onwards. Okay, if you look at the risk factors, there are some things which are what we call non-modifiable or constitutional, harder to change, and there are modifiable risk factors which are, if you like, predominantly environmental in nature, behavioral and so on, where we can make substantial impacts in terms of the cancer incidence by modifying some of these external factors. But what are the non-modifiable factors? They include things like having a personal history of the disease, such as of bowel cancer, a family history of bowel cancer, or other sorts of genetic susceptibilities which may or may not be detectable at the threshold of Mendelian sorts of genetics. So, for instance, there are new studies which look at various loci which may confer risk, and in time we may find that there are certain loci which give you higher risk, which of course you can't readily change. But what about the things that we can change, the so-called modifiable risk factors? At the top of the scale there is obesity and physical inactivity, but other factors include excessive red meat and processed meat consumption. There is a glaring omission on that slide, and that is fiber, where high fiber diets and vegetables, fruit, grains are generally protective. But more recently, there is increasing realization that alcohol is an important risk factor, and of course smoking is a risk factor for just about every bad disease you can think of. So smoking is bad. Right. There have been some very, very sophisticated sort of population-based and epidemiological studies, this one from David Whiteman's group in Queensland, looking at what proportion of bowel cancers, what percentage can be attributable to various risks. And here you can see the importance of fiber consumption, where perhaps as much as 18% of the proportion of bowel cancers can be attributed to inadequate dietary fiber intake, so fruits, vegetables, whole grain cereals, and so on. But equally significant is when you look at red meat and processed meats, so that, you know, in a society like ours, we have historically loved to eat red meat before the sudden or recent rise of veganism. But certainly red meat has been very, very much a popular thing consumed here historically, as well as processed meats. And by that I mean preserved meats. And it's thought that some of the nitrate compounds that are used in preserving might be important carcinogenic factors. Alcohol, I mentioned that it has become increasingly recognized as a risk factor for colorectal cancer, and the magnitude of that contribution is perhaps as high as 9%. Physical inactivity, 5%, body fatness, 9%, and often these two things go hand in hand, so that there's an additive effect which approaches 15%. And of course smoking, 6%. So all of these things, if we can substantially reduce these factors, the whole burden on society becomes significantly reduced as well. And overall, cumulatively, the modifiable risk factors make up to perhaps as much as 65% of the risk for bowel cancer. Okay. The purpose of this next slide is to show you that, in fact, in reality, bowel cancer is a very slow process which takes 5 to 20 years from when it begins to be recognized. And by that I mean it starts off as a tiny visible collection of cells, which we call a polyp, in which there are early neoplastic change, and it forms, if you like, a lump phenomenon. So you form a small mass, and over time this mass becomes a bigger lump, a bigger polyp, if you like, and then eventually the cells break through what's called the muscularis mucosa and have the capacity to invade. And it is invasion which defines cancer. So schematically, in theory, the rightmost part of the diagram shows you these invading cells that have broken through, and the mass is usually larger. So at that point you can see its apposition and its infiltration into vascular structures, which therefore then starts to give it potential to metastasize as well. So the important thing though is from polyp all the way to the right of the screen, cancer is a slow process, like I said, 5 to 15 years, maybe even longer, meaning that if we didn't see cancer at colonoscopy last year, it is likely that in 2 or 3 or even 5 years' time, there is still not likely to be a cancer. This is an important implication for how we choose to investigate people. All right. Cancer of the bowel has a very clear-cut relationship to the stage or the earliness, if you like, at which it is diagnosed. And so I've got there on the left a panel stage A, B, C, and D, which is also known as, if you like, comparable to stage 1, 2, 3, 4. And stage A is basically cancer which is confined to the superficial layers of the bowel. Stage A cancer has a 93% 5-year survival. So the vast majority of stage A cancers will be cured. Stage B, however, the cancer has spread to the outer surface, what we call the lamina propria, the muscular layer, the dominant muscular layer of the bowel wall. And once it is spread to there, the survival starts to drop down to about 82%. But stage 3 sort of marks another much more serious change in the prognostic implication. And there, the cancer has spread to lymph nodes, and suddenly you see the mortality, the survival is only 59% at 5 years. So you can see there's a quite dramatic drop in survival from there. And this includes usually with adjuvant chemotherapy and or radiotherapy as needed. Okay, so those survival figures are with the maximal therapies that are available now. Then, of course, we all know stage D is effectively incurable. There are rare cases where stage D, i.e. metastatic disease, there are rare cases where liver and or lung resection can actually still cure this condition, but they are rare. And so you can see there is a commensurate drop in 5-year survival down to about 8%. And in that 8%, we are not really talking about cure. We are talking, if we extended that 5-year to 6 or 7 years, you will find that even some of those 8% will start dropping off. So in fact, stage D, except for rare instances, is largely deemed incurable. So we are slowly building up to the whole theme of this presentation today, about trying to detect this cancer early. But suffice it to say, by and large, colon cancer is a disease where in its earliest forms, it has no symptoms. Polyps are tiny things which are essentially asymptomatic, and even when they become a small cancer, often it can be lurking there for a long time without anyone really knowing it's there. So by the time you actually start getting symptoms from bowel cancer, it usually is already a mass of a significant tumor size. And so once it's reached that tumor size, how does it present? Well, you can get bleeding, rectal bleeding, symptomatic anemia such as breathlessness, sometimes chest pain in people with less patent coronary arteries. There can be fatigue, tiredness, and so on. And then when you do a blood test, you detect that the hemoglobin is low. There can be changes in bowel habit, such as constipation or diarrhea or alternating. But of the two, diarrhea is the more important, curiously, and I'll talk about that in a moment as well. Abdominal pain can occur, but by the time they start getting abdominal pain, it may already be a sign of impending obstruction. The other way in which bowel cancer can cause abdominal pain is very extensive local neural infiltration, by which time it is often incurable. And then, of course, there is weight loss. But weight loss in bowel cancer almost always occurs with a localizing symptom, meaning with bleeding or with some other feature, because weight loss without those localizing symptoms rarely is caused by bowel cancer. Okay, so this is a very, very cleverly constructed chart that's put out by the Cancer Council, which is, if you like, an aggregate of numerous studies, and there's quite a significant literature behind this, in large part from general practice studies that have been done here and predominantly the UK, which look at all these different symptoms and a matrix of combinatorial symptoms which try and give us an idea of the sorts of things that we should be alerted to in terms of trying to find cancer. It gives us probabilities of of bowel cancer for a given symptom. And there are these boxes in red, which are understandably the most important or the highest risk probabilities of cancer, where it's over 5% risk if they have that symptom or combination of symptoms. If it's an orange, it's somewhere between 2 and 5% risk of cancer for those combination of symptoms. In yellow, it's a low risk, 1 to 2%. And then when it's a symptom which is in a white box, it is below 1% risk of harboring bowel cancer. So I just want to quickly clarify this notion of positive predictive value for people who are not familiar with it. It's basically the probability of the disease, if you like, for a given symptom. So if you look at it statistically, it is when you have a true positive, i.e. the disease itself, i.e. cancer, divided by all the people who have a positive symptom. So there'll be a lot of people with symptoms, but in fact only a small number of people will have cancer in this case. So similarly, you can look at it as looking at patients, symptomatic patients with the disease divided by patients with the symptom. Okay, so the probability of cancer for a given symptom. Okay, so armed with that, if we look at this chart now, which I've tried to highlight some of these things, let's look at the top row, which is just a single symptom presentation. So if we scan it from left to right, we start off with constipation. If a patient presents with constipation, there is a 0.42% chance that they will be harboring a colon cancer. So that means 1 in almost 250 of these people, only 1 in almost 250 will have bowel cancer. So constipation is one of these symptoms where people think that they have blockages, but actually it's not. It's usually caused by a generally hypotonic colon or some sort of defecatory abnormality because of pelvic dyssynergia and so on. It is almost never caused by an obstructive lesion of the colon, which presents with bowel obstruction, which is a different constellation to just plain old constipation. Diarrhea, on the other hand, you see the number goes up to nearly 1%. So diarrhea is a more significant symptom for colon cancer. And then the most dreaded of all, single symptom, which is rectal bleeding, we're talking about 2.4%. So again, the vast majority of people who present first off with rectal bleeding do not have bowel cancer. 97.6% will not have bowel cancer. It's usually hemorrhoidal, it's usually defecatory, tearing or trauma, etc., etc. Weight loss, you can see in itself, not a particularly suggestive symptom, 1.2%. Abdominal pain, 1.1%. Abdominal tenderness on examination, 1.1%. An abnormal rectal examination, that's an unusual one. It's only 1.5%, but it is really rare that someone has an abnormal rectal examination in isolation. So it's more useful, and I'll highlight it later, to think of rectal examinations in combination with some other presenting symptom. We don't go around just routinely performing rectal examinations on people looking for bowel cancer. Although many years ago, I think Julia Gillard's partner had suggested that men wanting to have early detection for prostate cancer should have rectal examinations. But I think they're talking about the prostate. Okay, hemoglobin, when it's sort of lowish normal, or sorry, the lower end of the normal range is 0.97%, so 1% risk of cancer, whereas when you start finding anemia less than 10, we are now getting into a more serious territory here, where the risk of cancer is 2.3%. Okay, so as I was saying, back to the issue of the abnormal rectal examination, when you look at it in combination with other symptoms, however, suddenly it becomes a much more important factor. So if we scan downwards, you can see with constipation, it raises the risk of bowel cancer to 2.6%. With diarrhea, it's up to 11%. With rectal bleeding, it's very high, 8.6%. Weight loss, 7.4%. Abdominal pain, 3.3%. And abdominal tenderness, 5.8%. Now, one of the problems with the abnormal rectal examination in terms of its relatively low positive predictive value here is because I think it's a technique that has become less and less employed. People are not so good at performing it anymore, hence they are less certain about what they find anymore. Often people feel cervices in the front, sacrum at the back, and they think they're feeling something. They might sometimes feel tampons and other things and get confused with a significant mass. So that probably is a reason why rectal examination is not necessarily so accurate. Whereas I think in the hands of someone who does a lot of it, there will be a much higher positive predictive value. Okay. What about other high-risk combinations? So I've circled the ones that are red. We've gone down the ones that have rectal examinations, but if you look at rectal bleeding occurring twice, so that's the isolated 6.8 point here, yep. You can see that if someone presents with rectal bleeding once off, the positive predictive value is only 2.4%. But if a few weeks later they present again, the likelihood of something significant is much greater. So if you look at other combinations close to that, there is loss of weight together with abdominal tenderness. It goes up to 6.4%. If you look at abdominal pain and a low hemoglobin, we're talking 6.9%. And if you look at abdominal tenderness with a low hemoglobin, we're talking, again, a significant number, like greater than 10%. All right. Okay, so those are very useful tools or instruments in terms of getting an idea of what are the sorts of symptoms and combinations of symptoms which should alert you to investigate people more aggressively. But there are also other high positive predictive value indicators which are not on that table, but I would like to bring to your attention nonetheless. One is a palpable abdominal mass. By that, usually we are talking about the right-sided abdominal mass, so a cecal or ascending colon mass, which is more easily palpable. The sigmoid mass, which is also palpable, is often fecal material in a contracted sigmoid. So that can be a bit less specific, but a right-sided abdominal mass is quite suggestive of colon cancer. Of course, imaging abnormalities, which is a common high urgency referral that we get, especially with now better technologies with CT scans, higher resolution, better radiological training to identify these things. They are often accurate in terms of us finding masses on CT and correlating that with cancer. And of course, nowadays we have a lot of patients, especially in major hospitals, who have PET scans as part of staging for other cancers, and lo and behold, there happens to also be lurking some sort of positive uptake in the colon, which is often either an advanced polyp, a large polyp, or an early cancer. Okay. In terms of diverticulitis, diverticulitis itself is not a risk factor for cancer, but after an acute attack of diverticulitis, we have to check for colon cancer, because 3 to 4% of acute diverticulitis can be caused by cancer. So if you like, cancer with some penetrating perforation can mimic an acute diverticulitis. Okay, but that happens usually after the first attack. If they have subsequent attacks and they have been colonoscoped and proven to be not because of cancer, then we don't have to keep repeatedly colonoscoping them. So it's after the first attack of diverticulitis, one should look for cancer. Okay, I've talked about colonoscopy, and colonoscopy is the best investigation if you're trying to look for colon cancer. It has a high diagnostic accuracy, 99.5%, which sounds high, but it is not absolute. We know that a small number of colon cancers are missed by colonoscopy, and perhaps as many as 5% of colon cancers were missed at a time when a colonoscopy performed earlier should have picked up something. So we know it is accurate, but not 100% accurate, but pretty close. The other advantage of colonoscopy, of course, is that you can obtain biopsies, And of course, it also has the capability of removing polyps, which, of course, thankfully prevents cancer in the future. I reiterate again the point that almost all cancers come from polyps, and by removing polyps, you will therefore remove a chance of that polyp ever becoming a cancer. Okay? Shall we answer the question? There's been a question. We'll make it interactive. So let's.
The question was, what age range do these PPV tables apply to?
Yeah. So the question was, what age range do these PPV tables relate to? And that's a very good question. There was a very broad spectrum of ages in numerous studies, but I think that you should think of it as applicable to all presentations that might occur in general practice. Probably, sorry, I've been cued that it's probably over 40 years old, yeah. Okay, so those tables were designed for people over 40, I beg your pardon. Okay, that's a very good question. I will show you some low PPV things, and that might partly explain something else there too. Okay, all right. So the other thing I want to talk about also is that I've alluded to the fact that symptomatic presentations occur when a significant tumor mass has already occurred. And I've told you that 25% of bowel cancers at the time of presentation are already at an incurable point. We know that if you count on symptomatic presentation, over 95% of people will need surgery to deal with the cancer, and only a very small number, less than 5%, will symptomatically present at a time where the cancer can be removed by colonoscopy and cured just by that colonoscopic removal. So the answer is that, so I've shown you all these tables and so on. I've told you that it's applicable to people over 40 years of age, but can we find bowel cancer at an even earlier stage? And of course, it comes to this other thing that I frequently talk about, and that is screening. And screening means we try and detect cancer when it is still asymptomatic. Okay, so we know that it's very important in bowel cancer because early detection in bowel cancer greatly increases the chances of successful treatment and survival. So there are many, many diseases that you will hear about in terms of screening. There are big screening programs that occur in terms of breast and cervix in Australia. There's always people talking about prostate. There are people talking about lung and so on. But by far and away, the champion of all screening diseases is bowel cancer, because it has a very clear-cut, well understood and well-established biology and technologies to try and deal with it. So it is a disease that has no symptoms during the early phases, so we have to try and hunt it by other means, and there are screening tests that can find it early. We know that early detection simplifies treatment, early detection improves survival, and screening has been proven to save lives. Okay, so there's a thing called the National Bowel Cancer Screening Program, where these kits are given out to people at different age groups, and it is anticipated that in the very near future, 2019, it'll be a full-on program. Every age group between 50 and 74 will get 2 yearly kits sent out to them. And if we're talking positive predictive value, a positive immunochemical fecal occult blood test in this program has a 4% chance of cancer being found. All right? So it's got a fair positive predictive value, and it has a good chance of catching things early. In fact, there is evidence now that screen-detected cancers, many of them are in stage A, 40% are stage A. Okay, there are some reasons why patients get delays in their diagnosis. Frequently, it is patients ignoring symptoms because of denial, fear, couldn't be bothered, can't get around to it, you know, it's not going to be me, etc., etc. Less commonly, some GPs say, well, you know, they examine the patient, they find hemorrhoids, and they say, well, it's most likely your hemorrhoids, don't you worry. but in fact there was actually a rectal cancer or some other lesion lurking a bit higher up, which was responsible for the bleeding. This can be a problem in younger patients where you don't really expect cancers to occur. And of course, one of the big things, sort of a small elephant nowadays, I hope, in the room is these delays in colonoscopy access. And most public institutions throughout this country and in many parts of the world suffer from terrible delays in colonoscopy access for people. If you look at colonoscopy in WA, there are over 70,000 of these procedures performed every year. Probably, that's 2014. By now, we could be talking nearly 80,000. Yet there are only about 1,300 colon cancers that are diagnosed for these 75,000 colonoscopies, which makes it about over 60 colonoscopies per cancer diagnosed. And we also have to bear in mind that 10% of cancers are not diagnosed by colonoscopy because they present urgently with an obstruction. So only 1.5% of colonoscopies find cancer in WA, and the figure is pretty similar nationally. So it's not a particularly efficient use of this resource. So if we want to improve colonoscopy access, we probably should try and target it more efficiently to target high positive predictive value indications and reduce the low positive predictive value indications. But also there is a big distracting demand for upper GI endoscopy, esophagogastroduodenoscopies. So in WA, 50,000 of these are done to diagnose less than 350 upper GI cancers. And so it's, we're talking about less than 0.7% of upper GI endoscopies find cancer, so even more inefficient. Okay, so by reducing upper GI demand, we can probably free up resources for more colonoscopy. So these are the low-yield colonoscopy indications where the positive predictive value is less than 1. Young patients with bloating. They virtually always have functional GI disease, such as non-ulcer dyspepsia or irritable bowel syndrome. Chronic constipation, as I mentioned before, is a low PPV indication. Surveillance intervals, which are too early. So the NHMRC guidelines and other guidelines often recommend 5-yearly surveillance intervals between polyps. And our findings is that if you request colonoscopy before that time interval, the chances of finding cancer is well below 1%, perhaps even almost 1 in 1,000. If there's a weak family history, so if the family member is not first degree, if they're old age, over 55, if there are a few members, again, it's a weak indication. And of course, as I mentioned before, a prior colonoscopy in the last 5 years makes a bowel cancer unlikely. Like all of these sorts of recommendations, the problem is always the isolated case where someone said, yeah, he had a colonoscopy last year, it was all clear, and then 1 year later he has his cancer. And these sorts of anecdotes, unfortunately, if you like, pervert the way we often practice. And all of us have had experiences like that where we drive for certain things when in fact the evidence suggests it's a poor use of resource. So the preceding slides, if you like, were the background to things, and so I just want to run a few cases through. I have another question. Sorry. Yeah. Okay. We are testing, as you know, we're testing these technologies, so there are a few things.
So the question is: do patients who have a normal colonoscopy within the last 5 years but have had a positive screening FOBT still need colonoscopy?
Okay, so the question is if you have had a positive a colonoscopy in the last 5 years, yet come back with a positive FOBT on screening, do you need to have another colonoscopy? The National Bowel Cancer Screening recommendation is that if they should participate after about a 4-year break from the last colonoscopy, and many people don't know that, and it hasn't been made clear yet. So ideally, if you've had a normal colonoscopy, you shouldn't participate immediately. You should have a time gap. But if you do find that there is a positive, the National Bowel Cancer Screening Program says you should not send them for a colonoscopy if they've had one in the preceding 3 years. So you don't need to send them. But unfortunately, again, beyond 3 years, you get into a zone where you found something in the screening test. So beyond that time frame, the recommendation is yes, they should be recommended for a colonoscopy after that. Okay? All right. So back to, yes, I can go back to this case. Case 1, a 66-year-old man, rectal bleeding lasting 2 weeks. He found some blood mixed in with his stool and also when he was wiping. Long history of constipation, occasional straining, normal rectal examination, normal blood counts, no previous colonoscopy. So I think, yep, you have seen some blood. That's likely to be important. He's a late middle-aged man. Okay, so you look up this chart. Yes, he's past 40, he's 66, is a likely candidate here. Rectal bleeding plus constipation, so his positive predictive value is 2.4%. Weight versus colonoscopy, he says, well, I'm 66. Can we just wait a little bit and see what happens? He presents 4 weeks later with further bleeding. And so if you go back to the table, at second presentation, the PPV goes up to 6.8%. So the right thing to do at that point is to organize colonoscopy. Of course, the PPV table shows you the PPVs, but no one has really told us about a cost effectiveness. At what PPV should we or should we not be referring patients? That is a much more difficult question to answer. Is a 1% pickup of cancer a justification for colonoscopy or not? Having told you that it's a low yield thing and it's an expensive use of resource, in time and in the future there will be better health economics that will confirm that for us. But at the moment there is an element of subjectivity about that. Okay, case 2, a 65-year-old woman previously well, weight loss 7 kilograms. She has dropped from 65 to 58 kilograms over 6 months. She feels that she's been eating things just the same. There are no other symptoms. Normal examination. Basic blood tests are normal. No real localizing symptoms. These are problems that we commonly see referred for all sorts of investigations when there are no localizing symptoms. So we look at the table again. She's 65, isolated weight loss. The PPV is only 1.2% for colon cancer. And even at second presentation, a few weeks later, her PPV for cancer is only 1.4%. So still pretty low, but nonetheless, she's booked for an upper GI endoscopy and colonoscopy because there is this notion that maybe there is a cancer slowly eating away all her nutrients and that's why she's losing weight. But like all of these things, 3 months later, because of access issues and so on, she's still on the waiting list. But her weight has started to increase again, up 2 kilograms to 60 kilograms. She still feels well, still no real localizing signs. And then further 3 months, her weight has remained stable. So a scenario like that is quite common, actually, including the waiting time, I must say. And in general, our experience is that cancer is highly unlikely without localizing signs. By that, we mean without any pains or other symptoms, without cough, without other breathing problems, with normal blood counts, normal blood tests, etc., etc. Weight loss in the absence of localizing signs or symptoms has a very, very low yield in terms of general investigations, and cancer is unlikely. It's usually related to reduced activity or age-related muscular atrophy, possibly with some low-level depression. Okay, case 3, 30-year-old woman. So she's out of this chart here, but I'll be told that I've used the chart incorrectly, but never mind. 30-year-old woman, otherwise well, long-standing bloating throughout various parts of the abdomen. She has a tendency to constipation, and she finds that when she moves her bowels, her bloating improves. She says she normally has a high fiber diet, and on examination there's nothing much to find. She's not particularly anxious, but just wanted to know whether this is something to be worried about. Okay, so if she was 40 and above, it shows you her PPV is only 0.42%. Well, that means that if she's 30, it's even less than 0.42%. Our experience is it's close to to 0%, but of course nothing is ever 0%. So nonetheless, constipation alone has a very low predictive value for colon cancer. So the hardest attempt will be now to try and discourage her from colonoscopy, because some people like the security of knowing that everything was all clear, but by and large the yield is very, very low. So it's a very expensive way to prove that everything is all fine. The more important point is how to manage her constipation, plus or minus managing her possible irritable bowel syndrome, and by that we would recommend regular laxatives, fiber, stimulant laxatives, osmotic laxatives. We need to dispel the myth to her that you shouldn't take laxatives. That is a myth. Our feeling nowadays is if you don't take laxatives, the problem gets worse. The colonic hypotonia becomes even more magnified with time. So you should take laxatives to try and encourage normal bowel habits. But unfortunately, there are some foods worse for bloating, and if you like, the most commonly talked about things are diets which are high in FODMAPs, F-O-D-M-A-P-S, FODMAPs, and sometimes gluten as well. And so some foods might need to be reviewed and adjusted to reduce the bloating. And of course, it's very important to try and reassure her that there is nothing seriously going on. Okay, case for 70-year-old man, ischemic heart disease, type 2 diabetes, BMI 35. This guy looks like trouble in terms of bowel cancer. Numerous risk factors, rectal bleeding mixed with stool, 6 weeks on and off. No pain, no change in bowel habits, normal bowel examination, but when you did a rectal examination, there was a concern that maybe there was an irregular feeling mass at the tip of the reach, the reach of the index finger. Okay, so GP became rather worried. So you looked up this table, yeah, he's in his 70s, he fits in, rectal bleeding, abnormal rectal examination, the positive predictive value is 8.5%. So the worried GP says, well, this guy is uninsured, you know, how can I fast track him? Because if I send in a referral, it could be months or weeks or whatever, he's uninsured. One of the best ways is to call someone. If it's Charles Gardiner Hospital, for instance, you could call me. Calls a gastroenterologist at a public hospital. The gastroenterologist says, yep, this sounds pretty worrying. Let's try and colonoscope him as soon as possible, arranges it. And sure enough, there was a rectal cancer as palpated by the GP. So that's a good pickup case. Okay, so that's about all I want to say before opening it up to questions. I'm not sure about the timing of things. I think we started a bit late with all our technological whiz-bangery, but we're there in the end with a few minutes left for more questions. But in summary, colorectal cancer is a very common cancer. It is mainly a disease of middle-aged and older-aged people. We know very definitely that early diagnosis improves outcome. Specific symptoms have higher positive predictive values of diagnosis. We should avoid over-investigating low PPV symptoms. We should encourage screening when they are asymptomatic, if they fit in, especially if they fit into the age groups for the National Bowel Cancer Screening Program, 50 to 74. They should just use the free kit sent by the government, tell them it's their chance to return something back to the government in a way that a piece of feces, which is a very rare opportunity for people to do something like that for the government. Okay, and then finally, colonoscopy is the best investigation if you suspect cancer. So I think at this point, that is about as much as I want to talk about, but I'm ready to field some questions.
Haven't got any questions yet? But
None yet? So we're waiting for some questions. Yeah.
Oh, here we go. I wonder if I should bring them to you.
Okay, all right, maybe I can see them. Nothing beats legs for here. What about inflammatory bowel disease and cancer risk? Okay, so that's a very good question. Inflammatory bowel disease, of course, is a significant cancer risk. And nowadays we believe that both in ulcerative colitis and in Crohn's colitis, if over a third of the colonic length is involved, there are significant risks of bowel cancer. However, overall, we believe now that the literature is overrated in terms of of its magnitude as a risk factor because of selection bias being reported mainly by tertiary hospitals that used to collect these sorts of data. But the general rule is somewhere between 8 to 10 years in colonic pancolitis. In ulcerative colitis, I beg your pardon, they should start to be surveyed, and the same in Crohn's colonic involvement, where over 30% of the colonic length is involved. In ulcerative colitis, where it's very distal, such as just rectum or just in the distal sigmoid, we do not consider that the risk of cancer is significantly elevated. Okay, next question. Would you consider FOBT screening in premenopausal females greater than 40 who have iron deficiency anemia? Yeah, again, a very good question. In fact, we are in the midst of updating the NHMRC guidelines for screening, and it has been shown to be cost effective to actually start screening at 45 years old, which is not answering your question, but at 40, and the government may suggest that that can be an elective thing, whereas the program will really start at 50. But at 45 onwards, it is already starting to be cost effective to screen these people. What about younger with iron deficiency anemia? Generally, we consider that that is a significantly important presentation that we would go straight for endoscopy and colonoscopy rather than filtering it one more layer by using an FOBT. There will be some new guidelines coming up. Again, they're all being reviewed at the moment, but for other symptoms which are of lower PPV, perhaps the FOBT as an extra hoop will be very useful. So, for instance, a young woman with constipation, someone with bloating, and so on, the FOBT might be a good way to go. But iron deficiency anemia, we would, even at 40, we would say probably an endoscopy and a colonoscopy. Endoscopy largely only to look for celiac disease, and if you do celiac serology, that's usually fine.
You kind of answered that question.
Okay, so the next question was, is it worth to perform FOBT prior to colonoscopy? So the answer is that if overt blood has been seen, the answer is no. And generally, up until now, we have only talked about FOBT as a screening test, not as a diagnostic test. But I think there will be new recommendations that will start recommending using FOBT in a much more adjunctive way where it can provide useful information, but specifically to try and stratify people who are of the lower risk indications. Last question, when should a young patient with rectal bleeding and no other symptoms, not mixed in with stool, have a colonoscopy? Oh, very difficult questions. Young person rectal bleeding, we think that it needs to be resolved at any age, especially if there is persistent bleeding over a period of 4 to 6 weeks. So a one-off flash bleeding in a young person in their 20s, we wouldn't worry about. But generally, if they represent again a few weeks or months later, we would say that is sufficient for them to be examined. Usually a flexible sigmoidoscopy is sufficient, but unfortunately in Australia, that has lost, if you like, popularity. The feeling is that generally if they come for a procedure, they come for a full colonoscopy. But in truth, a flexible sigmoidoscopy is often sufficient to look for what we're really thinking about when someone young presents with bright red rectal bleeding.